Dr. B. Bora, Cancer Institute, Guwahati. So I'll be presenting a case on differentiated thyroid cancer. So my patient is a 20-year-old female, student by profession, resident of Udalguri, Assam, coming with a chief complaint of swelling over neck for last 6 months. So coming to the history of presenting illness, she noticed a swelling over her neck for 6 months, which was insidious and progressive in nature. It was not associated with any pain, difficulty in swallowing or breathing. She noticed also another swelling over the left side of the neck for 3 months, which was insidious and progressive as well, without any pain. Coming to the negative history, no history of fever, no change in voice. There is no change in weight, no tremors, heat or cold intolerance, change in bowel habits, sleeping habits, or appetite. No significant past history, no family history of any thyroid cancer, no history of any previous radiation. She doesn't have any addictions. She's unmarried and her menstrual history is normal.
So Arnab, can you just go back to the beginning?
Yes, sir.
You just take a look. So 20-year-old. Okay.
Yes, sir.
And can you move to the next slide, please?
Yes.
So there were, okay. So there are two swellings which she has noticed.
Yes, sir. So the first swelling was she noticed 6 months back. It was not associated with any pain or difficulty in swallowing or breathing. And she noticed another swelling for 3 months, which was in the left side of the neck.
Understood. Can I have the next slide, please? Okay. Next slide. Right. So, why did you take the family history of thyroid cancer?
So in medullary carcinoma, there is a history of family history is important, and in papillary carcinoma, there are some certain familial syndromes, familial history like Cowden disease or familial FAP, adenomatous polyposis. So the family history of thyroid cancer is important.
And what about the history of irradiation? What's the relevance of that?
So most of the childhood papillary thyroid carcinomas are when they have a history of any previous radiation. For any other disease like lymphoma or leukemia.
I see. And so, I mean, as an examiner, the only comment I have on your history is that for a patient who's presented only with a neck lump, you have presumed this is thyroid or thyroid cancer. Your history seems to be completely oriented towards thyroid cancer. But imagine if this lump was a metastatic squamous cell carcinoma, your history would have been very different. So at least for completion's sake, if the only presentation is a neck lump, then your history should not be purely focused on thyroid cancer. It almost seems like you've made the diagnosis before you take the history. So be a little broad-based. Assess it as you would assess any thyroid, as any neck lump you would assess in general, right?
Okay, sir.
Okay, go ahead.
So coming to the general examination, her ECOG score was 0. She was average build. Pallor, sinus, icterus, clubbing, edema was absent. Pulse rate was 88 per minute. BP was 110 by 72. There were no hand tremors. There were no eye signs related to hyperthyroidism. There were no other medical comorbidities. Systemic examination, cardiovascular, respiratory system, abdomen were all normal. Coming to the local examination, on inspection, a 3 by 2 centimeter swelling involving the anterior portion of the neck on the left side was seen, which moves on deglutition but does not move with protrusion of the tongue. Overlying skin was normal. There was another swelling noted over the left level 4, which was around 4 into 2 centimeters approximately. So on palpation, the size was confirmed on palpation. The swelling was firm on palpation involving the left lobe of the thyroid. The surface was smooth. The skin over the swelling was pinchable. It was mobile with deglutition. Getting below the swelling was possible. And there was a firm mobile swelling over the left level 4 region, where the skin was pinchable, again, regular margins and surface smooth. There were no raised temperature. Trachea was in the midline, it was not deviated, and on Hopkins examination, bilateral vocal cords were mobile.
Okay, go ahead.
So coming to the investigations, her thyroid status was
Just if I can just
yes,
stop.
sir.
So what's your clinical diagnosis here?
So it's a thyroid swelling with a secondary neck node, is what I believe is a diagnosis.
So you likely think it's malignant thyroid pathology with
Yes,
neck
sir,
metastasis.
because it has a neck node, so most likely to be malignant.
Okay. Okay. What investigations would you plan for a patient like this?
So apart from the regular blood investigations, I would go for thyroid function tests. I would want to see her thyroid function, and after thyroid function, I'd go for a ultrasound neck.
So if I can stop you, what relevance does thyroid function have in her management?
So if the TSH is subnormal, or if then we can go for a scintigraphy. Then it will say that it's a warm nodule or a cold nodule. Generally, warm nodules are not malignant, and in general, malignant thyroid nodules are generally on the higher side of the TSH, normal, higher normal, or hypothyroid.
So you've made the general statement for a solitary thyroid nodule that you're evaluating.
Yes, sir.
This patient already has an apparent neck metastasis.
Yes, sir.
So my thought is that this is not relevant in this case.
Okay.
What you've described is if a patient comes to you with a solitary thyroid nodule, you would run the TSH. If the TSH is low, you're suspecting hyperthyroidism, and you would run a scan. Am I correct?
Yes, sir.
That's what you were saying?
Yes, sir.
Why would you run the scan?
To see the functioning of the nodule, if it's an isofunctioning nodule or a hypofunctioning or a hyperfunctioning nodule.
So in a patient with suppressed TSH, what are the two findings you may get on the scan?
We may get a warm nodule or a cold nodule.
So, okay, let me rephrase it. Okay, let me put it this way. When you run a thyroid scan in a hyperthyroid patient, you'll either get a hot nodule or a warm nodule, which is responsible for the hyperthyroidism, or you'll get a cold nodule in a background of hyperthyroidism. The hyperthyroidism has to be somewhere.
Yes, sir.
Correct? So either the whole gland has Graves and you've got a nodule arising in Graves, which is not functioning, or the nodule is an AFTN, autonomously functioning toxic nodule. Correct?
Yes, sir.
How does that matter in your management of a solitary thyroid nodule? Why do you do the scan? What bearing does it have as far as managing that patient is concerned? Let's say the nodule comes out to be hot. What would be your next step?
So then I'll suspect Graves' disease.
No, the nodule is hot.
Then it's a benign, most probably benign, not malignant nodule.
What would you do?
So I'd go for
So are all hot nodules benign, or are there exceptions to the rule?
so there are exceptions.
What are they?
Currently, sir, I'm not being able to recall.
It's okay. It's all right. In adult, generally hot nodules are benign, and textbook recommendations say you can even forego doing an FNAC.
Yes.
But in pediatric population, be aware hot nodules often are functioning cancers. So in pediatric patients, be aware a hot nodule may not have the same connotations as an adult with a hot nodule. So anyway, I mean, if it's a hot nodule, yes, you're likely in an adult, 20 years, you're likely dealing with benign. You may not need an FNA, and you'll treat it like an AFTN. Whether you choose iodine or surgery is your decision with the patient.
Yes.
But if it's background hyperthyroidism, means Graves' disease, and you choose to operate this patient, then you are better off choosing a total thyroidectomy. So not only do you handle the nodule, but you also handle the hyperthyroidism in the same operation.
Yes,
So
sir.
that's why you do the scan, because you want to know, is only the nodule the pathology or is the whole gland pathological? And that may temper what kind of operation you may eventually do.
Okay.
In this patient, I don't think there is a role for a scan. You have apparent neck metastasis. Even if the nodule is hot, I don't see you foregoing an FNAC or choosing no surgery for this patient. Correct?
Yes,
So
sir.
in this patient, what investigations would you like to do?
So firstly, I'll go for an ultrasound neck, and followed by FNAC of the nodule as well as the neck node.
Okay. All right. What findings on ultrasound of the neck raise suspicion for cancer? Papillary thyroid cancer. Let me be specific.
Okay. So it will be most probably hypoechoic, echogenicity, one. And then the component of the nodule, if it's solid, mostly solid component. And then it's microcalcification, or rim calcification. And so the shape of the follicles are taller than wide shape. And lastly, maybe vascularity but vascularity has not yet been given in the thyroid score in papillary. In follicular, it has been given. And so irregular margins and ill-defined margins or irregular margins.
Extrathyroidal extension.
Extrathyroidal extension, yes.
So if you see any of these features, your index of suspicion for cancer is very high.
Yes.
What's typical about metastatic thyroid nodes? Is there any finding you typically see in metastatic thyroid nodes?
So there are generally microcalcification, they're generally hyperechogenicity, and they are generally rounded in shape in the nodes. And the cystic component is also there.
Excellent. So cystic nodes, and sometimes you will see microcalcification.
Yes.
Any other pathology you know where cystic nodes are known? Cancers, any other cancers where you get cystic nodes in the neck?
HPV.
Yeah.
HPV.
Yeah. HPV positive oropharyngeal cancer can also have cystic nodes in the neck.
Yes, sir.
So if you see that as a finding, think of these two as primary sites.
Yes.
Okay, excellent. Okay, so you'll do an ultrasound. What information do you want on the ultrasound?
So I look for those findings and the size of the nodule as well as the position of the nodule. Where is it, if it's posteriorly located or if it's abutting the surrounding structures like the esophagus or the trachea. And to see also the nodal status, the position of the node.
I think that you know clinically already. What
Yes,
additional information do you want on the ultrasound?
So on the central compartment, may be assessed by the ultrasound. So any central compartment node, we cannot get it by palpation. So that can be assessed by ultrasound.
What else? Contralateral neck? You want to look at contralateral neck?
Yes, sir.
And you would also want to look at level 1.
Yes, sir.
Because that's not a normal site of thyroid cancer metastasis and you may not clear it routinely.
Yes, sir.
You must check it. You can occasionally find metastasis there or rarely. So you want to make sure you're not overlooking it accidentally because that's not a level you'll normally clear at surgery.
Yes, sir.
I think ultrasound is for central compartment is in general not a good tool. And that's because the thyroid gland and the sternum both interfere with good assessment of the central compartment. So it's not your best imaging tool for central compartment. Okay.
Yes.
And what other imaging would you consider in this patient, or are you going to be happy with the ultrasound?
So since so I will also go for a CT scan because she has nodes in the lateral node in the lateral compartment. So So as you said, the central compartment can be better assessed with a CT scan, and then also find out the retrosternal extension if there is any. But in the examination, there was not. I could get below the swelling, and it will give the other nodal status as well. And if the nodule is abutting the esophagus or is infiltrating the esophagus or trachea, I'll find it out on CT scan. And if there is any parapharyngeal extension as well, then CT scan may be helpful.
Parapharyngeal extension of?
The thyroid, if there is any extrathyroidal extension.
Extrathyroid. Okay. Okay. So to summarize, two main reasons. One, to assess extrathyroidal extent of disease.
Yes, sir.
And number two, to look for lymph nodes in areas where the ultrasound is relatively blind.
Yes, sir.
Retrosternal, superior mediastinal, retroesophageal, paraesophageal, parapharyngeal. These are areas where the ultrasound is relatively blind, and
Yes,
the CT can show you a better idea. These are also areas you don't routinely clear in your standard on-block neck dissection. So it's an area where you can leave behind disease if you didn't assess it preoperatively. Any concerns with using contrast in a CT?
So it said that it's not that much of a concern for radioiodine therapy if it's required post-operatively, that much of a contrast. But if the patient is allergic to any contrast, then we can forego the CT scan and go for maybe an MRI.
So how long would you wait after a CT contrast before you administer iodine?
We generally wait for 3 to 4 weeks. So anyway, so by then it should clear out.
My understanding is not always. It's the clearance for iodine is depending on how great your kidneys are working, and that's highly age dependent. So in children and young adults, there is data that 4 weeks is adequate. Most people will clear the iodine in 4 weeks. But you have somebody who's elderly, you probably would like to wait 6 to 8 weeks because they will take longer to clear. If you need to give it early, you can always check a urinary iodide level.
Yes.
And see is the iodine content down. In this patient, yeah, probably 4 weeks will be enough.
Yes, sir.
And for PTC, because the disease is so indolent, a few delay in by a couple of weeks in administering iodine is almost never going to affect your overall outcome. So you're never in a rush to give iodine in 3 weeks or 4 weeks or 6 weeks. That's never going to make a difference in a well-differentiated papillary thyroid cancer. Okay, go ahead. Can you, what is the, any other test you would do? You said you would do thyroid function. You could do ultrasound. What is the third test you would do? Or you would do a CT as well, you said. Anything else you would do?
So FNAC.
From where?
From the nodule, and as well as if she has a lateral neck node, so generally we should go for a FNAC from the neck node as well.
Okay, from the thyroid nodule and any other significantly enlarged lymph nodes in the neck.
Yes,
what
sir.
if the node cystic? Like you told me, the node can be cystic.
Yes, sir.
But the FNA is likely to be inconclusive in that case because all you'll get is fluid.
Yes, sir. Then
anything else you can consider in that case to prove or disprove lateral neck disease?
So if the ultrasound findings of a nodule is high risk, then even if the FNAC comes out to be inconclusive, then we may go for the lateral compartment clearance.
You could do a thyroglobulin washout.
Yes, sir.
So in a purely cystic node, you could do a thyroglobulin washout. The cutoff values are not really standardized,
Yes, sir.
but a very high thyroglobulin level in the fluid would strongly indicate this is metastatic thyroid cancer. So that confusion will generally not happen when you have a 4 centimeter node on the same side as a thyroid primary. That would happen if you have a 7 mm node with a small cystic component and you're not sure whether this is worth doing a lateral neck dissection for or not. This case is clinically obvious. Imaging is not going to change your plan here. But you may need that test occasionally if you're dealing with very questionable nodes of questionable size with a cystic component where the FNA is just inconclusive because all they aspirate is a bit of fluid.
Yes.
Okay, can you just go ahead with your investigation findings, please?
So the ultrasound neck. So the left lobe shows iso to slightly hypoechoic space occupying lesion with ill-defined irregular margin located more on the posterior aspect, measuring approximately 35 into 15 mm, abutting the esophagus, and significant increased vascularity is noted. Another 45 into 15 mm left nodal mass with tiny calcified foci scattered in the solid component in level 4. There was another nodal mass 18 into 7 mm in level 4 and 10 into 5 mm in level 3. No significantly enlarged lymph node was seen on the right side of the neck. So TYRX was given as TYRX 5. So highly suspicious of malignancy.
So based on these findings, would you order a CT in this patient?
So yes, sir, because it's more posteriorly placed nodule and it's abutting the esophagus. So I'd go for a CT scan.
And there is already high volume nodal disease apparent. So you have to look
Yes,
at all the blind areas as well.
Yes, sir.
Okay, perfect. Go ahead.
Coming to the CT scan findings, the ISO2 low attenuated mass showing heterogeneous enhancement in the left lobe of thyroid, which was compressing the left lateral wall of trachea. There was no retrosternal extension. A hypotenuse lesion separate from the primary mass was seen in the left side of the neck in levels 3 and 4. So, there was no mention about the esophagus thing on the CT scan actually.
So when you looked at the films, what was your impression?
So it was not infiltrating the esophagus. It was just, so I have the CT scan.
Yeah.
So
why don't you walk us through the CT now? Yeah.
So this is a axial cut CT scan with contrast. So here we can see the nodule. We can see the thyroid gland, and you can see a hypoattenuated mass with a irregular margin posteriorly placed on the left side, which is close to the trachea as well as the esophagus. And there seems to be no compression of the trachea, and with the vessels, it has a clear margin.
What about extrathyroidal extension? What is your guess on this?
On this CT scan finding, I am not seeing any extrathyroidal extension as of yet, but with the esophagus, there is a plane, so I think there might be no extrathyroidal extension.
With this scan, what structure is at risk for injury?
The nodule is more posteriorly placed along the tracheoesophageal route, so the recurrent laryngeal nerve is at high risk.
Absolutely. I mean, when I look at this scan, I think the chance of extrathyroidal extension is very high.
Yes.
You may not have esophageal or tracheal infiltration, but this nodule would almost certainly be extending beyond the posterior capsule. And as you said, I think involvement of recurrent is likely. Yes. It may be savable. I'm not saying it will be sacrificed, but the patient definitely should be consented in this case that we may have to sacrifice the nerve, or we have a higher chance of paresis because you may need to peel it off the cancer.
Yes. Yes.
But I think that's a genuine concern here on this case. And as you said, I agree, the vessels look to be clean.
Yes,
and I don't think there will be an issue with resecting this in general. Yeah.
Yes, so there is a lateral neck node on the level 4, which is seen on the left side. So that is also free from the carotid, it seems.
Is it in relation to the carotid? I don't think it's in relation.
It's not in relation to the carotid, with the prevertebral muscles. Yes, sir. And sternocleidomastoid muscle also seems to be there is a plane.
Right.
That plane.
Right. Okay, go ahead.
So to rule out any retrosternal extension, so I have given this.
Okay.
So the FNAC came out to be papillary carcinoma, that is the 6.
Right.
And so my final
So if you
diagnosis.
could just go back. Let's talk a little bit about FNA.
Yes, sir.
This is FNA from what site?
Sir, actually from the nodules.
From the nodule. Okay.
Nodules, sir.
Okay. Can you tell me a little bit about what are the microscopic features of papillary thyroid cancer?
So there is psammoma bodies present. There is orphan and nuclei present, which is characteristic of papillary carcinoma, of thyroid.
Anything else?
Uh,
So you may have a papillary growth pattern, right? They have very distinctive nuclear features, like you said.
Yes, sir.
Intranuclear inclusions, orphan nucleus, elongation, overlapping, grooving. There are characteristic chromatin features. And a lot of this diagnosis of PTC is on nuclear features.
Yes, sir.
Now, as a clinician, I think it's important that you must learn to recognize these, because when you read the FNA report,
Yes,
just don't rush to the conclusion by the pathologist. Look at the cytological description and see that you feel it's consistent with the final diagnosis. And if you have any questions, always you should freely discuss with your pathologist to make sure that you are both understanding the case correctly. That's less relevant when you have a Bethesda 6 in front of you, where the features must be very overt and very obvious, but a lot more relevant when you have a Bethesda 5, 4, or 3.
Yes, sir.
Okay.
Yes, sir.
That's where you must be able to recognize yourself, the characteristics that they're describing, and whether how strong the index of suspicion of cancer is based on that.
Yes, sir.
Very, very important. Thyroid is one area you must have a good understanding of pathology. You should be able to partly read the FNAC report yourself. Okay. Especially if you don't have a dedicated high quality cytologist who reports your cases. If you're going to rely on community-based FNA, you really need to be able to read it at least to some degree yourself. So what's the risk of malignancy in a category 6, Bethesda category 6? In fact, why don't you just tell me the risk of malignancy in all the Bethesda categories?
So coming to the first, Bethesda 1, it's indeterminate. So Bethesda 2 is benign. So it's at around 3.
Bethesda 1 is
Bethesda 0. Bethesda 0.
No, Bethesda 1 is not indeterminate. It's inadequate.
Inadequate.
Very different than indeterminate.
Yes, sir.
So what's the risk of malignancy in inadequate? And what is the criteria for saying the specimen is adequate for reporting?
So we should at least get 6 groups of cell, 6 groups of cell where there are 10 epithelial cells, 6 groups with 10 epithelial cells. And then at least if it is not meeting the criteria, then we term it as inadequate.
Yeah, 6. I remember it as 612, but you're
Yes,
right.
sir.
It's 610 or 612, 15 means 6 follicles with at least 12 cells in each, roughly. That's a rough guide.
Yes, sir.
Okay, but 610 is actually, I just remember 612 because it's easier to remember. Okay.
Yes, sir.
And what's the risk of malignancy in an inadequate specimen?
Yes, sir. Around 3%.
Very low.
Very low. Yes,
Very
sir.
low. Okay. Next, Bethesda 2.
Yes, benign, sir. So in benign also, sir, it's very low, around 0 to 3% chances. Then coming to Bethesda 3, which is ATP of unknown significance. Here the risk of malignancy is around 5 to 15%. And then coming to Bethesda 4, which is follicular neoplasm.
No, wait, go slow.
Yes, sir.
So you're talking of Bethesda 2007, isn't it? 5 to 15%. There is a new revision to the Bethesda system which is being proposed. Are you aware of it? Bethesda 2.0. No. So I'll just let you know a little bit about it. So what you found in AUS is that 5 to 15 was proposed by the Bethesda system to be the ROM or risk of malignancy in this category. But when the majority of institutes analyzed their own data, they found that the risk of cancer in what they report as AUS is generally higher. It ranged from anywhere from 6% to almost 50%, but it averaged around 16 to 18%. So AUS probably has a higher risk of malignancy than what Bethesda proposed it should be. And in the new Bethesda, they have now revised the risk of malignancy in category 3, and they've raised that risk of malignancy.
Yes, sir.
Right? Okay. Anyway, go ahead. And Bethesda 4
is follicular neoplasm, where it's around 15 to 30% risk. And Bethesda 5 is suspicious of malignancy, where it's around 60 to 75%. And then Bethesda 6 is almost 98, 99% chance of malignancy.
Okay. Excellent. So based on these tests, what is your management plan?
So I'd go for a total thyroidectomy with a central compartment clearance, along with lateral left selective neck dissection, levels 2, 3, 4, 5.
Okay. Go ahead. Tell me, what did you do then? Do you have more case or your case ends here?
So my case ends here.
Okay. So your case ends with diagnosis and what you would plan to do.
Yes, sir.
Why would you clear the central compartment in this case?
So because the lateral neck node is involved, so there is high chance of involvement of the central neck node as well. For that, and for any disease which has lateral neck nodes, we generally go for central neck clearance. Or any other T3, T4 disease, then we go for central compartment clearance.
Is there an exception to the rule that there is lateral neck disease, the central compartment must be involved? You're right. This is the general rule because the first echelon of drainage is the central compartment.
Yes, sir.
So if you have manifest disease in the lateral neck, it is presumed there is disease in the central compartment already.
Yes, sir.
Is there an exception to this rule? Upper pole tumors.
Yes, sir.
So tumors in the upper pole of the thyroid can spread directly to level 2 at times without spreading to the central compartment first. So you can have an exception in upper pole tumors, but generally, as you said, it is a rule. If you have lateral neck disease, you will have central compartment disease also. Okay. You said you also do a central compartment in T3, T4 tumors.
Yes, sir. In extrathyroidal extension, generally go for.
Why do you do it? What do you think is the benefit to the patient by doing that operation?
There might be some subclinical disease in the nodes in the central compartment in a high volume thyroid disease. So it's better to clear the central compartment.
No, I agree. No, I meant in terms of what do you think the direct benefit to the patient would be? Improved survival, reduced recurrence? Like, why are you doing it? Disease, microscopic disease in the central compartment is very, very common, right?
Yes, yes.
Depending on how carefully you assess, you may see it in between 50 to 90% of patients if you use highly specific assays, IHC, PCR, etc. But we know that clinically, not so many patients recur in the central compartment, right? So there is a discordance between microscopic positivity and that ever reaching clinical significance, correct? So if you do it in T3, T4, what is the end point? What is the gain? Yeah, are you doing it for survival improvement or recurrence decrease or both?
So for, I think both, sir. For survival and for recurrence as well.
No, I think the data suggests that you don't impact survival by elect. Yeah, hello.
Hello, sir.
Yeah, sorry. I think I lost electricity. I think I got disconnected.
Yes.
So now I was saying data doesn't support that you impact survival.
Yes.
Data supports you may reduce recurrence. Right?
Yes.
It's, as you would know, it's controversial. Not everybody ascribes to that school of thought, but you should know why you do it if you're going to do it. It's not to improve survival. That I don't think has been shown. That electric central compartment will alter that outcome. Okay. Would you, how big was this primary you said? Size on ultrasound?
Size on ultrasound was around 3.5 into 1.5.
So would you consider a hemithyroidectomy in this case?
Sir, with the lateral neck node, sir, no.
So is there any case you would consider a hemithyroidectomy which is proven PTC?
So if the ultrasound features are not high risk, so if there are high risk features, then we have to go for that. And also, sir, molecular testing may be important in
No.
one to 4 cents.
No. I am saying this is proven PTC.
Okay, sir.
What patients of proven PTC can be appropriately treated by a hemithyroidectomy?
Sir, any 1 to 4 centimeter nodule without high risk features and ultrasound can be taken up for hemithyroidectomy.
What are high risk features? What do you mean by that?
So on the ultrasound, if there is ET, extrathyroidal extension, or the other high risk features, then like the solid component is there in the nodule, then we will go for total. So if there is absence of any other high risk features like the echogenicity and the calcification, then we may go for hemithyroid.
No, I think you're confusing two things. High risk features on ultrasound which raise suspicion of cancer are different. I'm talking a case where it's proven PTC on an FNA already. So hypoechogenicity, taller than wider, irregular margins, doesn't matter. It's proven PTC already.
Yes, sir.
Right? Which proven PTC would you think can be appropriately treated by a hemithyroidectomy? You correctly said there should be no extrathyroidal extension.
Yes, sir. And no nodal mass. So
no nodal disease.
Yes.
Okay. Anything else?
No.
So if you look at the guidelines from the ATA, in a tumor that is 1 to 4 centimeters, who's not at extremes of ages,
Yes.
has no nodal metastases or distant metastases, has no extrathyroidal extension, and whose opposite lobe is normal, and no prior history of irradiation.
Yes,
if you meet these criteria, you can offer hemi as an alternate to total. Means both can be considered, but there are pros and cons of both. So that's a separate discussion. But at least at your level, you should know what the guidelines state as a criteria where you can consider a hemithyroidectomy. And of course, in tumors less than 1 centimeter, again, if it's unicentric tumor, it's not all over the thyroid, it's not multicentric, there's no radiation.
yes.
A hemithyroidectomy is the appropriate treatment. At least in the guidelines, there is no role for a total thyroidectomy in a less than 1 centimeter tumor. Obviously, no extrathyroidal extension, opposite lobe normal, no history of radiation, etc., etc.
Yes,
Right?
yes.
Okay. All right. So how would you, what stage is this patient? You never told me what stage this patient is.
So I was coming to that in the diagnosis.
Okay, so please go ahead. Sorry, I interrupted you.
Yes, sir. It's a stage 1 disease. Since the age is less than 55. Clinically, it was T2N1B.
Okay.
T2 because 2 to 4 centimeters and 1B because of the lateral node.
Okay. All right. Stage 1. Excellent. There is suspicion of extrathyroidal extension in this patient.
Yes, sir, but the report didn't say anything about that.
No, I agree.
Yes, sir.
I'm not, I agree with you.
Yes,
I am saying if you were to find extrathyroidal extension intraoperatively, how would it change your staging as far as the T stage is concerned and as far as overall stage is concerned?
So if there is if there is gross extrathyroidal extension, then it becomes T4A to the trachea, T4A to the trachea or to the esophagus and if it's going to the prevertebral muscle or the carotid sheath, then it's T4B. And the stage per se, if there is no distant match, then it will stay as stage 1.
Okay. And what about the recurrent nerve involvement, which we all agreed was one of the concerns here in this patient?
So definitely with extrathyroidal extension with the posteriorly placed nodules, it is at high risk.
And recurrent nerve involvement would put this stage where?
Recurrent will put it in a T4A.
Okay. What about if this disease is extending through the straps, which is very unlikely in this case because it's posteriorly located?
So straps generally T3 disease.
More specific, can you give a better answer than T3? T3A or T3B?
T3B. T3A is microscopic. T3A.
T3A is more than 4 centimeters.
Yes, sir.
Somebody may correct me, but I think microscopic extrathyroidal extension has now been removed
T3
from the T staging. That's no longer part of your T staging. Okay, how do you define microscopic extrathyroidal extension?
So on the final histopathological report, so if there is extrathyroidal extension with the capsular breach, then we can say is to be microscopic extrathyroidal extension.
I think there were 2 criteria stated, which is extension into the strap, the sternothyroid, or into the perithyroidal fat. These would constitute as microscopic or minimal extrathyroidal extension. Okay. If at surgery you find this tumor, the recurrent laryngeal nerve is plastered on the cancer, but not grossly infiltrated, and the patient had mobile vocal cords preoperatively, how would you handle it?
So we try to save it. We try to, if there is no gross involvement of the recurrent laryngeal nerve, then we'll try to shave it off and peel it off from the tumor.
Okay. And what do you think this patient's likely avidity for iodine would be? Is this likely to be a radioactive iodine tumor, avid tumor or not?
So it's most likely to be.
Most likely to be. Why do you say that?
Because of the age factor and
yeah, young people,
young patients. Yes, sir.
Young patient, and if pathology shows classical PTC, then it's likely to be iodine avid. So I think you did pretty well on the case. I'm just going to ask you some general questions now on thyroid cancer, but I think you did fairly well with your case. Congratulations.
Thank you, sir.
What do you know about active surveillance?
So active surveillance is generally done in papillary thyroid microcarcinomas less than 1 centimeters, because so we can observe the patients if there are no high risk features, and if there are patients with medical comorbidities, so who cannot go for surgery, then we can actively we can go for surveillance in those cases.
So less than 1 centimeter tumors, no high risk features, you said.
Yes, sir. And no yes, sir. And no nodes.
No nodes.
And yes, sir. And if it's if it's more posteriorly based nodule, then but in a recurrent rangeal nerve or the surrounding structures, then we may go for thyroidectomy in those patients.
Right. In fact, if there is doubt that it may involve the recurrent or the trachea, then you must proceed with thyroidectomy.
Yes.
These are exclusion criteria for surveillance. And what is the general outcome of such small papillary thyroid carcinomas when they are observed over time?
Generally, they're very indolent. So, so in a elderly population, generally they are very much indolent. But in young population, then we may see them transforming to papillary carcinoma.
So whose work are you
in,
quoting? This is you're obviously quoting somebody's. Like, do you have any?
so it's it was a RCT from Japan. So,
right.
Ito et al. I don't exactly remember Ito et al.
You're correct. It's not an RCT. It's a observational trial by Ito for these tumors, and they observed. They published results on over 1,200 patients that they observed, and in periods of 5 years, they found progression in only 5% and nodal metastases in about 2%. This is over a 5 years observation period. So that's what they proposed active surveillance based on. It's not widely practiced standard of care around the world. It's one of the options you can consider in patients with small PTC who don't have high risk features, where progression may not involve the trachea or the nerve. And you're correct, progression is less common in elderly and was seen more frequently in younger people. So that's where the concept of active surveillance comes from. Okay. When you do a central compartment clearance,
yes, sir.
as you will in this case,
yes, sir.
What is the morbidity, added morbidity to the patient over and above what you get with the total thyroidectomy?
So generally, the recurrent rangeal nerve is at higher risk in that when clearing the central compartment, or if there are nodes which are.
I will give you four complications: permanent nerve injury, temporary nerve injury, permanent hypoparathyroidism, temporary hypoparathyroidism. These are 4 risks for operating in the central compartment. In general,
Yes, sir.
which ones are likely to happen, which are not related to central compartment clearance?
Sir, nerve injury is related to the central compartment clearance rather than hypoparathyroidism. More likely.
No. If you look at the published meta-analysis, the complication that consistently is correlated with central compartment clearance is temporary hypoparathyroidism.
Okay.
And not really. Of course, there will be case-to-case difference. You're right. If I have high volume central compartment nodes enveloping the nerve, of course, in that patient, chance of temporary nerve paresis is higher than the average case. But in general, if you look at elective central compartment clearance. The real complication that in good hands you're worried about is temporary hypoparathyroidism. At least that's what the meta-analysis support, right? Okay. In this patient who is T2N1B, what is your estimate of risk of recurrence following your treatment?
So it will be
Well, let me rephrase it, Arnab.
so.
Can you tell me how nodal disease is related to risk of recurrence?
So it will be in intermediate risk, or at least with the size of the node. Then I think recurrence will be around. Can figure out the number.
Okay, no problem. Can you tell me, when you look at a patient with nodal disease on final pathology, how do you interpret the nodal disease in terms of what kind of nodal pathology or volume correlates with recurrence? Do you have any way you stratify the patients in your mind?
So according
You
to
read a
the
pathology report post-op.
according to the size, if there was any extracapsular extension of the node.
Okay.
So
Size, extranodal extension.
Yes, sir.
Anything else?
Number of nodes as well.
Number of nodes and size of the metastatic deposit.
Okay.
Right? Less than 5 nodes or small microscopic deposits are
Yes,
generally associated with a low rate of recurrence.
Low risk. Yes,
under 5%. Right?
Yes,
Nodes which are large, particularly more than 3 centimeter, or
Yes,
those with extranodal extension, you're looking at 20 to 30% rates of recurrence.
Yes,
Right? These are general figures. When you specifically look at this patient, you're looking at a young patient, you're looking at likely radioactive iodine disease, avid disease. Maybe it will be lesser than the general quoted, but that's how you subjectively assess. But you should have some idea of how nodal volume generally correlates with risk of recurrence. What's the impact of nodal disease on mortality in this patient? Is this patient of higher risk of death compared to a patient who doesn't have nodal disease? Same age, same primary.
So mortality, I don't think there will be is a factor.
Is nodal disease ever contributory to mortality? So in the elderly, or if there is gross extranodal extension, these are there are two times when nodal disease may contribute to mortality. But this patient, unlikely. As you said, she's young, and the disease, at least on the scan, looked really ovoid with no apparent extranodal extension. So probably not in this case. Right?
Yes.
Okay. What's dynamic risk stratification? Are you aware of?
Yes, sir. So after the completion of the radioiodine therapy, so we generally assess the patient with the TG levels, thyroglobulin levels, after the completion of the treatment. So that is dynamic risk stratification has been divided into 4 types, as excellent response, as structurally response, and then biochemically positive response and indeterminate response.
Sorry. Go again. I didn't get the 4 categories clearly. You said
excellent response.
Okay.
There is biochemical presence of the disease without any structural component. There is
Biochemically incomplete.
biochemically incomplete.
Right.
Then structurally there is incomplete, and then
Right.
there's indeterminate response.
Okay. Excellent. Excellent. And I assume you know how these eventually turn out over time, these 4 categories, right?
Yes.
So dynamic risk stratification says that you assess your response to treatment
Yes, sir.
about 1 year after treating, and the response to how they respond, how the disease responded to your treatment makes you shift the recurrence. For example,
Yes.
you may have started with an intermediate risk cancer,
Yes.
right, at initial
Yes.
staging. But if you get an excellent response to treatment,
Yes.
then that patient likely has the recurrence rate similar to a low risk cancer, around 2%. So dynamic means that you change the stratification of where you started based on how well your cancer responded to the treatment. And obviously those that respond well will get downgraded, and those that don't respond well will get upgraded
Okay.
in terms of risk of recurrence.
Yes, sir.
Okay, so you said, what are the tools you use for surveillance of this patient? Let us say this patient gets iodine, maybe 30 millicuries for remnant ablation, because there is a little bit of a hotspot in the bed.
Yes.
Okay. And no other disease is picked up outside the thyroid bed.
Yes, sir.
How would you carry out surveillance on this patient?
So initially on 6 months, we go for a thyroglobulin, 6 to 12 months, thyroglobulin level and ultrasound of the neck. So to see any presence of disease or any elevation of thyroglobulin. So
Would you do a stimulated or an unstimulated thyroglobulin?
Better to go for stimulated.
Would you do an iodine scan or not?
I don't think so, sir. In this case, 30 millicurie, if there's thyroglobulin is in control and ultrasound shows no other features, then
I think if you've done a remnant ablation, then it's sense to do a scan on surveillance and see whether your ablation was successful or not.
yes.
Right? So you would, at least on the first follow-up, do a iodine scan.
Initially, yes, sir. On follow-ups.
On first follow-up, you would.
Yes, sir.
If you have successfully ablated and there is no uptake on the first follow-up scan, then you can forego doing that in future. But certainly if you used iodine, you must know how well it worked. And that's because if you don't successfully ablate the remnant, then the risk of eventually picking up disease in the thyroid bed is around 20-25%. So a successful remnant ablation is very reassuring.
Yes.
You get it? I mean, if you used iodine, I think it's important to do at least one scan to see whether it worked or not. And whether, whether whatever you were trying to ablate, you've successfully ablated or not. And if you have, I agree, you can then forego scans going further.
Yes.
Right. Anything else you do when you order a thyroglobulin? Is there anything else you must do?
So anti-thyroglobulin antibody levels should be assessed. Yes.
Always. You cannot interpret thyroglobulin in the absence of anti-thyroglobulin antibodies. In other words, a absence of thyroglobulin doesn't mean much unless you also show that you don't have elevated anti-thyroglobulin antibodies. Okay. What's TENIS? TENIS.
So thyroglobulin elevated but negative iodine scan. So the tumors are non-radioactive iodine avid, but still there is a elevated thyroglobulin.
Right. So you have elevated thyroglobulin, but the whole body scan does not show any disease, correct? Iodine scan.
Yes, yes, sir.
What tracer do we use for whole body scan in iodine?
So most commonly we go for iodine 131, and iodine 123 can also be used.
Yeah, ideally iodine 123.
Yes, sir.
It has better imaging properties than iodine 131.
Yes, sir.
I think it's because of higher proportion of gamma rays that get picked up better on the scanning tool, but it's not available in India, so we use I-131. Okay. So if you have a patient with the elevated thyroglobulin, let's say it's around 30, the thyroglobulin goes up to 30 on post-op follow-up, your whole body scan does not show any disease. The iodine scan, what would you do next? In other words, how do you investigate a patient with tennis?
So we go for a PET scan to look for any other, to look for metastasis generally, or any other recurrence.
Okay. And what do you think is the sensitivity of the PET scan in picking up disease in these cases?
In non-radioiodine avid cases, so it's more sensitive.
No, in a patient with tennis,
Uh,
with the thyroglobulin of about, let's say 30, how sensitive would a PET scan be in picking up disease? So you're right, the book answer is a PET scan, but the book was written by nuclear medicine specialists, right? So you must keep in mind that the sensitivity of the PET scan to pick up disease is directly proportional to the thyroglobulin level. The higher the TG level, the more likely your PET will show something. And if your TG level is low, let's say 10, 5, 8, 15, 20, your PET scan majority of the times will not show much. And with low TG levels, generally you're looking at disease in the neck, right? Only with high TG levels do you start thinking of lung or bone metastases, but those levels are normally in hundreds or thousands.
Yes, sir.
So if you have only a modest level 10, 15, 20, 25, it's reasonable just to do an ultrasound of the neck, because if you have disease, it's likely to be in the neck and the PET may not necessarily be your best test. So you could do an ultrasound or you could do a CT, cross-sectional imaging. But you're right, the book answer is PET scan, but you should be aware that the sensitivity of PET scan is directly proportional to TG levels. You start seeing TG above 100, the PET scan is an excellent test for picking up disease.
Yes, sir.
Right?
Yes.
Okay. So in a patient with PTC, let's say this patient on your CT, which you did for the neck, also showed, covered a bit of the chest and also showed some lung nodules, highly suspicious of metastasis.
Yes, sir.
In this particular patient.
Okay.
Would that change your approach?
So my dose,
this patient?
so my dose for radio ablation iodine will increase. So I will increase to around, in pulmonary metastasis, it's around 150 to 200 millicurie.
So you would still operate and you would still.
Yes, sir. Yes.
Okay. What are the factors that impact curability in patients with PTC who have distant metastases?
So if they're non-Rai-avid, then
okay,
that is
so
one.
iodine
And
avidity.
then, yes, sir. And the age factor is also there in elderly patients.
Okay. Anything else?
Uh, if it's any metastasis to the brain, maybe then it's usually a bad prognosis.
So lung does better than other sites.
Yes, sir.
Younger do better than older. Obviously, iodine avid does better than non-iodine avid. And micronodular does better than macronodular. Right?
Yes.
So yeah, distant metastases are curable, but there are many factors that affect the chance of cure or how well your iodine will work in that setting. All right. For a patient with progressive symptomatic metastatic papillary thyroid cancer, which is not iodine avid, are there any drugs you're aware which you can use?
So there have been some clinical trials, some tinibs, sorantinib, and
Sorafenib and
I forgot the other name. Uh, those have been in Lisa.
lenvatinib.
Yes, sir.
So decide and select trials.
Yes,
I'm not going to tell you much about it, but I mean, you've done fairly well. I think you should read this and you should absolutely know this because there is level 1 evidence showing their efficacy. And as you know, in thyroid, there are very few things proven by level 1 evidence. So go back and make it a point to read this over the weekend. The two trials on lenvatinib and sorafenib. But yeah, those are the two options you have for progressive symptomatic metastatic disease. Okay, you mentioned molecular testing at some point,
Yes, sir.
right?
Yes, sir.
So when do you order molecular testing in a patient with thyroid cancer? Or not thyroid cancer, sorry, thyroid nodule.
Sir, with a Bethesda 3 or 4, or in a Bethesda even 1, we can go for molecular testing. So in ATP of unknown significance, to know whether it's a malignant or a benign disease, we can go for molecular testing. So there are some rule-in testing and rule-out testing. So most commonly BRAF, then RAS, then third mutation, then PAX8. These are ruling to rule in any malignancy, and to rule out, we generally use 167 GEC to say that it's a benign disease.
Right. You mentioned you would use it in Bethesda 1. Is that correct?
So so we generally go for in a Bethesda 1, we generally go for repeat FNSC.
Yeah, there is no role for molecular testing in Bethesda 1.
Yes, sir.
You need to have sample of the atypical cells to be able to run a molecular analysis on them. Bethesda ones, we really don't have cells. So there's no point. In fact, even when you order a molecular test, it's very important that your FNA has definitely shown pathological cells. There's no point running an FNA on a sample that picked up normal thyroid tissue accidentally. You understand what I'm saying?
Yes,
So
sir.
yeah. So molecular testing in category 3, 4,
4.
and possibly also 5, although that is debatable. These 3 constitute what is called the indeterminate categories.
Yes, sir.
3, 4, and 5. And are you aware of any test available in India? What is it? How does it work? What are the results of that test?
So in our region, we don't have this, but BRAF mutation I heard, but yeah, we have not used it. I have not seen it being used.
So what's the sensitivity and specificity of a BRAF mutation?
It has got a high positive predictive value for papillary.
Yeah, very high positive predictive value,
Yes, sir.
but not a very high sensitivity.
Yes, sir.
Roughly about 50% of PTCs will express BRAF. But if you see BRAF, then the diagnosis of PTC is almost certain. So it's a great rule-in test. It's not a great rule-out. So the rule-out test that's available in India is Afirma. Do you know anything about this? Afirma is the proprietary name. That's the gene expression classifier you talked about.
GC, yes.
Yeah. So do you know anything about the Afirma?
It has got a high negative predictive value to rule out malignancy.
About how much?
So about, I think 90%, 90 to 95%.
About 95% in Bethesda 3 and Bethesda 4,
Yes.
and about 85% in Bethesda 5. So yeah, excellent negative predictive value. That's why it's a good rule out test.
Yes.
That's a firma. Okay. Let's go back a little to basic workup. Sorry, I actually didn't ask you. You are what course are you in right now? What are you doing?
So I'm pursuing fellowship in head and neck
You're doing
surgery.
fellowship in head and neck. Okay. And you're in first year or second year?
It's a second year.
Okay. So your exam going.
Yes.
Okay. Excellent. Let's go back a little bit. What are the indications for an ultrasound guided FNAC?
So if there is a cystic nodule, then better off going with a ultrasound guided. And if it's a more posteriorly placed nodule, then also we can go for an ultrasound guided FNAC, and the size as well. So if there is high risk features and it's a small size nodule, then we can go for guided FNAC.
Is an FNAC indicated in a cystic nodule?
So in a mixed nodule, better.
Okay. So in a mixed nodule, why would you do it under ultrasound guidance?
So we may generally, if we do blindly, then we may just get the cystic part and miss the solid part. So,
okay. Excellent. Also repeat FNACs.
Yes, sir.
So if you want to complete the wrist, a repeat FNACs recommended to be done on ultrasound guidance if the first sample was inadequate. You have a better hit rate and a better sampling rate. Okay. When would you order a biopsy on a thyroid nodule? Are there any situations you would order a biopsy?
So for diagnostic lobectomy or just
A biopsy, a core biopsy. Or would you never order a biopsy?
Generally we don't, so, but
are there any situations you would ever seen or you've read where you might want to order a biopsy?
in thyroid lymphoma, I'm not sure.
You're right. You're right. If thyroid lymphoma is suspected, or where a diagnosis of anaplastic thyroid cancer is being considered, and the FNA may not be conclusive in those cases. These are two situations where you might want to order it. The third, which is very rare, is Riedl's. Sometimes that can be difficult to diagnose on an FNA. And because Riedl's mimics cancer in terms of rapid progression, pain, and a hard mass, you want to be very sure you're not overlooking cancer. So you may want to do a core biopsy at that time. Right? But yeah, you would sometimes order in suspected ATC or suspected lymphomas. Right? What lymphomas are more common in the thyroid? And are there any predisposing conditions to developing lymphoma of the thyroid?
B-cell lymphomas are more common.
Yeah, DLBCL is very common, diffuse large B-cell lymphoma.
Yes,
Probably the commonest variety you see. This is aggressive lymphomas.
yes, sir.
Any condition predisposes to lymphoma?
The radiation history.
Underlying Hashimoto's.
Okay.
They have a tendency, higher tendency to develop lymphomas. Okay. All right. So Dr. Anju, Dr. Kanan, are we there?
Yes, sir.
Yeah, hi. Dr. Kanan, would you like to go ahead? I've spent a lot of time with him. I think he's done very well. And if there are any questions from your side, I think we have 10 more minutes. Then please, please go ahead.
Yeah, Dr. Kalita, well done.
Thank you,
And
sir.
Dr. Sareen, you've given us a lot of information. You're brimming with knowledge. And I want to ask you this. Dr. Sultan always used to say that if you had to have a cancer, it's better to have a well-differentiated papillary thyroid cancer. But in real life, that's not really the case, you know. How many of these have landed up with laryngectomy, for instance, in your hands? I mean, papillary cancers keeping on recurring and you're just going after them, and finally you land up with laryngectomy.
Yeah. Yeah, Dr. Kanan, I have never done one, but it's also possible the profile of patients I see can be different. And this is very important when we look at PTC, that, you know, depending on where you work, the profile of cancers you see can be remarkably different. So you're right. I think if Dr. Pradhan sir says it's right, I can just add a rider to that, that if God were to give me a cancer, give me a well-differentiated thyroid cancer, which is intrathyroidal and with no nodal or distant mets, then the chance of cure is exceedingly high. So the issue mainly, I think, happens when you have extrathyroidal extension, which is a very adverse factor for both recurrence and poorer survival. So yeah, I think if it's intrathyroidal, you are doing to do great. But if it's not, then it may not be such a great outcome. Somebody, there are some chats at all. There are some chat questions. I think
Yes, sir. If you can answer one of them,
I
that
can
is
try. Some of them are very tough for me. So I-131 half-life is 7 days, but patients are discharged in 2 days. Why? I can't answer that. I think a nuclear med would tell you, but I think they basically wait for the radioactivity to drop to a certain level at a certain distance. And once that is there, they discharge. But they do give precautions to avoid contact with small children, pregnant women for at least 2 weeks. So it's possible you are still radioactive, but that activity may not be high enough to hurt a regular person. But certainly children and pregnant women you have to stay away from. So M status is decided pre-op or post-op. I think for a differentiated, well-differentiated thyroid cancer, like what was presented today, it would normally be post-op. But if I have a elderly patient, for example, who has a disease with clear extrathyroidal extension, and surgery would require extirpation of the trachea or possibly extirpation of the esophagus. In other words, an extended operation that would carry some long-term morbidity, I would do a metastatic workup pre-op. It would help me prognosticate the patient better and just put the patient and me on the same page as to what are our goals of treatment here. Are we really hoping for cure, or are we only aiming for loco-regional control? That being said, one would still strive for loco-regional control as best as you can, because loco-regionally progressive disease, as Dr. Kanan just mentioned, is much worse to deal with in thyroid than distant metastatic disease. So you would still do your best to loco-regionally cure, but your goals of treatment would change if you have determined wide, high volume metastatic disease, let's say in an elderly patient, which is not likely to be very radioactive iodine, and almost certainly your treatment is not curative in the long run. So I would use it in select situations. I would do a metastatic workup pre-op, not generally. Why calcium doesn't drop in immediately, but PTH does? This is excellent question. So this should go to Dr. Arnav. Arnav, are you still there?
Yes, sir.
So the question being asked is, Following thyroidectomy, PTH may drop immediately, but calcium takes generally 2 days to fall. Why so? So finally, we found a question you can't answer. Huh? You can add it to your list of weekend reading to be done. Huh? Lenvatinib, sorafenib, and PTH calcium.
Yes.
Okay, let me help with that. So the intact PTH molecule has a very short half-life, 3 to 5 minutes. So what we test for is generally the intact PTH molecule. It also depends what generation tester you're using, but generally like second generation testing and all generally tends to test for more or less the intact PTH molecule. That degrades very fast. So if your parathyroids are hurt or excised or perished, your PTH will drop. But PTH has many, intact PTH will drop. But PTH has many active metabolites. And if you look at the PTH molecule, it's 84 amino acids long. And a lot of the activity is in the first 34 amino acids at the N end, I think, N terminal end. The first 34 amino acids are one that carry the activity. So when the intact molecule breaks, you may still have broken polypeptides that are still active in maintaining calcium. And they have a longer life, half-life of being degraded further. So the calcium, that's why may take longer to drop because these active metabolites keep maintaining the calcium level. And that's why the nadir of calcium fall will generally be seen at 36 hours, even though the PTH, intact PTH, I will say, will drop within a few minutes. I hope that answers the question. There's one, management of papillary carcinoma and thyroglossal cyst in a post-operative setting. So, yeah, the diagnosis often gets made post-op, but it can be done pre-op. If you see microcalcifications in a thyroglossal cyst, strongly suspect PTC. I've seen 3 patients in my life. One was diagnosed post facto after excision. 2 were actually diagnosed pre-op. So where we had a pre-operative diagnosis, it was easier to manage. We carefully looked for whether there is any extra cystic extension of the disease. And we took a wider cuff of muscle around the thyroglossal cyst. You also want to assess the thyroid gland very carefully for 2 reasons. One, sometimes these patients don't have the thyroid gland. All the thyroid tissue is in the thyroglossal cyst or tract. But if there is a thyroid gland, you want to make sure there is no multicentric tumor. If there is, a concomitant thyroidectomy must be done. I don't think there are any guidelines that tell you what is the right management protocol because it's so rare. It's very, very rare, and there are very few case series from which you can draw conclusions. But I tend to treat it similar to how I would treat cancer in a thyroid gland. If the tumor is breaking out of the thyroglossal cyst, I will do a thyroidectomy and use iodine. If it's a small PTC within a thyroglossal cyst with clearly no extra thyroglossal cyst extension and the thyroid gland is normal, I may just do a thyroglossal cyst trunks operation and watch the patient. So similar principle to how I would treat a PTC arising in the thyroid gland. If it's within the gland, thyroidectomy is good enough. You don't need iodine generally. If it's outside the thyroid, you would not want to do iodine. You would want a total thyroidectomy in that situation. So same principle. What is the follow-up protocol? So the follow-up protocol for a patient with DTC is titrated to how do you risk stratify the case. So as you understand, broadly, you can look at patients as low risk, intermediate risk, and high risk. High risk is going to need the most intense follow-up protocol. Low risk will have a more liberal or less intense follow-up protocol. You will dynamically risk stratify all patients, which means depending on how your follow-up is going and what results are coming back, you will in your mind keep reclassifying patients as do they need more intense or a less intense protocol. The tools that you use standard for follow-up are thyroglobulin along with antithyroglobulin, imaging in the form of ultrasound, and a whole body scan. These are the general rules, the general test you will use. You may also pull in a CT, MR, PET scan, etc. as and when needed. But let's leave that out of the equation. Now, of these three tools, if I have a low risk case, generally I'm happy to monitor with a thyroglobulin and an ultrasound. Also, if I've used iodine, as remnant ablation or as adjuvant therapy following surgery, I will do one iodine scan at least after that. And if the tumor is completely, it's not tumor, if there is no uptake, which means the thyroid is ablated and there is no tumor, I generally won't do iodine scans in future unless the thyroglobulin rises, indicating there is tumor regrowth. So in short, for low risk tumors, generally I'll do thyroglobulin, ultrasound, and it will generally be a non-stimulated thyroglobulin. So the patient doesn't have to be withdrawn of thyroxine. On the other hand, for patients where I think they have a high risk of recurrence, you would be doing a stimulated thyroglobulin at least a couple of times. You would be doing ultrasound, and you may also be doing whole body scans. But this is dynamic. It's not what I do in the first year will follow for every year. If the patient's free of disease, you will gradually de-escalate the level of testing. The last thing to keep in mind is how much thyroxine suppression to keep patients on. And again, there is nice data from the, I keep forgetting the full form. It's very difficult to remember. The National Thyroid Cancer Cooperative Surgery Group, NTC, CSG, some very nice data from those papers, which basically says, again, you look at patients as low risk, intermediate risk, high risk. Low risk are those, who have innocuous tumors, who have excellent response to therapy. In them, you don't need to suppress the TSH. You can keep these patients in the normal range on the lower side, 0.5 to 2. In fact, many surgeons would say you don't even need to keep them in 0.5 to 2. Anywhere in the normal range is okay. In a low risk case, there is very little role for TSH suppression. In an intermediate risk group, I like to keep the TSH in 0.1 to 0.5, which is just below the normal range, but not terribly suppressed. And again, if for a few years the patient does not show disease, he will get re-stratified as low risk, and I may allow the TSH to now return to the normal range, 0.5 to 2. In a high risk case who has obvious metastasis and you're trying to keep the metastasis from progressing and growing, you would drop the TSH below 0.1. You don't suppress nowadays to undetectable levels, which used to be a school of thought earlier. You just suppress below 0.1. But even when you suppress somebody below 0.1, you have to be careful to watch for cardiac arrhythmias and osteoporosis with long-term suppression, especially in the elderly. And obviously, generally, metastasis and bad disease is more commonly seen in the elderly. So always be aware that if you're suppressing the TSH very low, you're looking for arrhythmias and you're looking for bone loss in the long run. And you should definitely be doing that with help of an endocrinologist if you're suppressing below 0.1. So that's the general follow-up protocol for testing as well as the TSH suppression. I think there's a word on NIFT-P. Arnab, how about you?
So it's
Quick short note on NIFT-P, and I'll add on whatever I know to that.
So it's a non-invasive follicular type, follicular neoplasm or capillary-like features. So it's an encapsulated tumor, generally very indolent tumors. And
do you know the diagnostic criteria? You should. If your exam going, you should. It's a recently described entity. Not only should you be aware of this in clinical practice, but you should. It's a high likelihood exam question also. You should know. I think add that to your list, NIFT-P. So what I know about NIFT-P is recently described entity. Yuri Nikiforov is the one who proposed this classification. And basically, if you look at PTC, you have what's called FVPTC, right? The follicular variant of papillary thyroid cancer, which has a growth pattern follicular, but nuclear features of PTC. And FVPTC is then divided into infiltrative or encapsulated, which means it has a capsule or it's diffusely infiltrative. The infiltrative generally has features similar to PTC. More often you'll find BRAF mutations. They behave a bit more like classical PTC. And the encapsulated are more commonly have the RAS mutation and behave a bit more like follicular thyroid cancer. In the encapsulated, you then divide them into invasive or non-invasive. Invasive means the capsule is invaded. Non-invasive means the capsule is not invaded. So NIFT-P is a select subgroup of encapsulated, non-invasive FVPTC. And there are a few other criteria that must be met. There shouldn't be any papillary growth pattern seen. And if BRAF testing is done, it should be negative if it is done, right? So basically you're looking at a very indolent, encapsulated, non-invasive tumor akin to papillary thyroid cancer. The reason they gave this new terminology is because when these patients were followed up, who met this criteria, when patients with this kind of histological picture were followed up, recurrence or metastasis was almost unknown. I think one patient out of 140 or 145 in the initially proposed study developed distant metastases. So because it's an almost certain cure cancer, they thought that take the word cancer away and remove the stigma that the word cancer carries. And that's why they said classify them as NIFT-P. It remains a surgical disease. Generally with NIFT-P, surgery is what you would do, and the diagnosis is always made post-surgery. You would not generally do a total thyroidectomy. If you did a hemi, that's considered adequate. There is no role for iodine. I tend to keep these patients on follow-up just because the diagnosis of NIFT-P can be subjective. And just in case your pathologist has made an error, you still want to keep them on follow-up and see how they're doing. But you treat them like the lowest risk thyroid cancer in your patient population. I hope that answers that. So there's a last question. I think maybe that could be the last one. We had time till 8. We're probably a bit beyond 8 already. Arnav, I'm going to put this to you. It's a surgical question. What are the principles of ligating the superior thyroid artery and inferior thyroid artery in today's day and age? How do you handle these two vessels while doing a thyroidectomy? What are your concerns? What do you look for? Why do you do it one way or the other?
So we generally ligate close to the gland nowadays.
Which one? So tell me superior separately and tell me inferior thyroid artery separately.
Superior, nowadays we go for close to the gland.
Why so?
So to preserve the superior parathyroid supply, blood supply.
How frequent is the superior parathyroid supplied by the superior thyroid artery?
So incidence is very less. Mainly the 90% is being supplied by the inferior thyroid.
Yeah, my impression was 20% of the times. So yes, one reason is that you may have a branch going to the superior parathyroid and you don't want to ligate that branch. So you ligate the artery as close to the gland. But what's the bigger reason? It's not so much for the superior parathyroid supply. You do it close to the gland for another reason.
Because of the external bunch of the superior laryngeal nerve. So,
correct. lesser chance of injury if you ligate the artery close to the gland.
Yes, sir.
Nowadays, most surgeons would actually try and identify the branch in Reeves space, which is the space between the thyroid and the cricothyroid muscle. And if you can see the nerve, then you push it away from your surgical field and ligate your vessels where you visually make sure the nerve has been preserved. This is more important when dealing with the Cernia type 2B, where the nerve could actually be crossing over the superior pole of the gland, where even if you ligate the artery close to the gland, you're still going to cut across the nerve.
Mhm.
So, but yeah, that's the principle for that. How do you handle the inferior thyroid artery?
Uh, the inferior thyroid artery, generally we do that also do the close to the gland only nowadays.
Do you ligate the main trunk?
Like it the branches.
Yeah. By the time you get to the thyroid gland, the inferior thyroid artery main trunk has already divided into multiple branches. So you're absolutely right. Today's um, um, concept of doing a thyroidectomy is you ligate the branches at the point where they enter the thyroid. You don't identify the main trunk more proximally as used to be done in the past.
Yes, sir.
Why do we do this? Why have we changed from proximal ligation to now distal most ligation at the point where they enter the thyroid?
So because of the parathyroids. Yes, sir.
Correct. Because the blood supply to the parathyroids, you don't want to transect the artery proximal to where the branch to the parathyroids will go. You want to take the branches more distally so that you preserve parathyroid blood supply.
Yes, sir.
Excellent. Excellent. I think we've got across most of the questions, and it
Yes, sir.
was a pleasure. Thank you very much for inviting me. It's always great to interact with students, and it stimulates your head and it gets your memory cells working, because we also tend to forget these things in daily life. And Arnab, you did well. I really do think you
Thank you,
did
sir.
well. Use this as a stepping stone to just increase your knowledge.
Yes,
If you just sit in clinic and for every decision your consultants make in your head, you think why, that will and just go back and answer that question at home by looking up literature. You will learn a lot. That's all. Everything your consultants do, they have a reason why they're doing it. Always think why. And if you just answer that question, you will gain great amounts of knowledge. And certainly, I hope you made a list and read up a couple of things, and hopefully all the best. You should do great in the exam. You should do well.
Thank you, sir.
Thank you.
Thank
Thank
you
you,
very
Dr.
much, Dr. Sareen. Thank you very much. I think that's called surgical instinct. It's not, it's really. Thank you very much, sir.
Thank you, Dr. Kanan. Thank you for the opportunity. Good night.
Good day.
Thank you so much, sir. Have a good day. Bye-bye.
Bye.